Welcome to the Golden Hour, the podcast community where moms and moms-to-be hear stories from other mothers and top experts in the pregnancy and postpartum care field. You can visit goldenhour.fm for more information, resources, and all other episodes. You can also find us at goldenhour.fm on Instagram for comments and questions. All right, welcome to the Golden Hour. I'm your host, Dr. O. Today's guest is Cheruba Prabakar, a board-certified OBGYN and fellowship-trained minimally invasive surgeon who is truly reshaping what personalized, compassionate women's healthcare looks like. She's nationally recognized for her expertise in fertility-sparing fibroid surgery and advanced endometrial care, work that's been life-changing for so many women navigating IVF and hormonal challenges. Through her practice, La Marinda Gynecology and Surgery, Dr. Prabakar empowers women from the very first period through menopause and beyond, blending evidence-based medicine with accessible, holistic approach. She's also a certified menopause practitioner, a passionate myth-buster when it comes to hormonal therapy, and a global advocate for girls' education in South India. You may have seen her featured in outlets like Arise America or Essence Magazine, and today she's here to share her expertise with all of us. I'm so excited to welcome her. Welcome, Cheruba. This is an episode that's been long in the making.
Yes, thank you so much for having me. And I admire so much of your work. So I am thrilled to be sitting here with you, chatting.
The feeling is mutual. So it's always good for an episode where we start off fangirling. I was saying when in the pre-pod that we've been trying to plan this for a year. And so I know that this is going to be totally worth it. You also started our kind of pre-recording giving me the best compliment ever. You thought that I was a Zara model. And I'm like, if I'm giving model vibes right now and I'm post-call, that's amazing. That's amazing.
That is amazing.
Yeah, that's like
Accolades.
that's really great makeup I'm working with right now. Anyway, this is really going to be an important conversation. I think it's going to be really empowering for so many women. My goal in the inception of this podcast now over 2+ years ago is to empower patients, right? There's so much fear that we see. We see so many women that are dealing with mixed messages and social media full of so much misinformation and myths to be busted. So I think this conversation is going to leave a lot of people walking away feeling empowered and well-informed. So I'm so grateful for you.
Thank you. Thank you for having me.
So let's start from the beginning. Before we actually kind of get into the meat of the conversation, I want to learn about you, the human behind the white coat. What made you get into not only OBGYN, right? We all have our origin stories, but what made you decide to specialize in minimally invasive surgery, specifically fibroid and endometrial care?
Yes. So I trained in New York. So I am an East Coaster. And where I trained in Long Island, I just saw a lot of patients with fibroids and endometriosis. This is during residency. And as I was thinking of like, okay, what next? I knew I wanted to do something, hone in a little bit more on surgery, and was lucky enough to get one of the few spots at that time for minimally invasive surgery, also in New York, in Brooklyn. And the patient population was such that we just ended up doing a lot of fibroid surgery that became like our niche in that fellowship. And so when I finished my fellowship and got a job, it so happened that I ended up all across the country in Oakland with a very similar population to where I trained. And so I was thinking, I just did a lot more of fibroid surgery and endometriosis. And when I finally left corporate medicine to start my own practice, I was like, oh, what should I kind of brand myself as? What do I really want to be known for? And it just kind of came naturally that, I should be known as the fibroid doc. So that's
Yeah.
sort of where that came from.
Yeah, I love it. Yeah, like that is your brand, and it's such a special niche. And you're right, it's fibroids affect certain populations of women disproportionately. Do you want to speak to any statistics around fibroids while we have an attentive audience?
Yes, yes. So we know that 80% of women will be diagnosed with a fibroid by the time they're 50. This is all comers. And then women who are of color, it actually bumps it up to 90%. So this is a very, very common problem, and it's something that we're not talking about enough. We don't have enough research on, we don't have enough policy on, we don't have adequate screening guidelines on. So this is a big problem worldwide. And when you start thinking about your aunt or your grandmother or maybe your mom, a lot of women will say, "Oh, yeah, they had a hysterectomy. I'm not really sure why." Often it's because of fibroids. So this is a really big problem. And in my practice now, I see women all the time who had no idea that they had fibroids or no idea that it could impact them the way it does, and they're suffering from bleeding and infertility
Mm.
and all of these issues. So it's something I'm so passionate about, and I think we can do a lot better for women when it comes to fibroid care.
Yeah, preach, sister. I 100% agree. No, in my family, I happen to come from a family that has a large proportion of women. My mom was the oldest of 9, and of her 8 siblings, 7 of were women, so I have tons of cousins, and somehow that X chromosome is very strong, so I have tons of female cousins, and in my family alone, it's probably pretty regularly that I get, like, a family consult from a cousin who has fibroids. My sister has fibroids, my mom had a hysterectomy for fibroids. I feel very fortunate that, yes, I have a fibroid, but my fibroid is pretty tiny, but you're right, it affects so many women. I mean, that quote, 80% of women by age 50, let alone African American women having such a higher rate of that. I When I think about fibroid care, I think about my family, right? I think about the people that mean the most to me. I think about how it affects not only their ability to conceive, but pregnancy risk if the fibroids aren't taken care of in prior to pregnancy or postpartum. So this conversation is not only for the listeners out there, but it's for the people that I love the most. So I'm ready to dive in deeper. When we
Yes.
think about fibroids from your expertise, and for listeners who aren't necessarily in medicine, but might be kind of in going through like the heart of fertility challenges, what do you think that most patients don't understand about fibroids and fertility that you absolutely think that they should?
Yeah, so I think so many women, first of all, they don't know what fibroids are, and many women don't ever get a scan of the uterus prior to getting pregnant, or even when they haven't been able to get pregnant, or they've had, maybe a few miscarriages. That's sort of the point at which they kind of enter the medical system for imaging. And
Mhm,
so a lot of fibroids could have been picked up way earlier on and could have been monitored for size or impact on the lining of the uterus prior to conceiving. And I think it's really important for our listeners to understand that fibroids can definitely affect fertility, either prevent you from getting pregnant or present some serious complications once you do get pregnant. And so it's really, really crucial to know if they are in your uterus, where they are, how big they are, and all of those things.
yeah. And let's get down even more to the nitty-gritty. So how can fibroids impact someone's ability to get pregnant, and what are some of those specific complications that could occur in pregnancy if the fibroids aren't necessarily removed ahead of time?
Yes. So fibroids, it all comes down to size and location. So some fibroids may be tiny, they may be 1 or 2 centimeters, but they could be right inside the cavity where a baby would form. So this could prevent an embryo from implanting correctly in the lining because it's taken up by this small fibroid or multiple small fibroids. Or if an embryo was to implant, it could lead to a slightly increased risk of miscarriage because this fibroid is essentially pushing the embryo off, or maybe the embryo is sort of somewhat implanted, not fully in the lining, but partially
Mhm,
on the fibroid, things like that. So location is totally, is really crucial in
mhm,
figuring out how it's going to impact us. And the second is size. So maybe you do have a 1 centimeter fibroid, but it's not in the cavity. Maybe it's in the wall of the uterus. Maybe it's kind of hanging off the side of the uterus. Then, it's probably not going to affect fertility in any way because of where it is and its location. Now, if that same and at the same location, if you had a 10 centimeter fibroid,
yeah,
that would be a different story because a 10 centimeter fibroid is, I mean, that's large and it can also grow during pregnancy. And when we think about how fibroids affect pregnancy, it can just provide less space for the uterus to grow. So it
mhm,
can create growth restriction. And I think the bigger issue is they can degenerate. And this is
mm,
something I saw a lot in residency where the
yeah,
fibroid loses its blood supply because the blood is going towards the baby as it should, and then the fibroid starts to kind of lose its blood supply and start to secrete all of these inflammatory chemicals and cause a lot of pain, and women feel like they're in labor. So yeah, it can really create havoc, and some are
Yeah.
lucky that they don't have any symptoms, and that's great, but it's so hard to predict who those people are gonna be.
Yeah. No, it's so true, and that is such a great segue to the next question, and this one I think is a bit more controversial, and that's the whole point of having a podcast is to ask the hard questions. And that there's this delicate balance in medicine of prevention. Preventive healthcare can have such lasting positive effects, but then there's also this category of doing too much and over surveillance and kind of leading to sequelae of potentially complications that could have been avoided. And so when I think about fibroids, and I would love to learn from you how you counsel your patients as the fibroid doc. When I think about fibroids, I oftentimes tell patients same thing. It's about size and location, thinking about potential pregnancy complications if fibroids left alone, whether it's impacting the ability for babies to grow, pain related to degeneration, postpartum hemorrhage, etc. But then it's also that delicate balance that depending on where your fibroid is, you're also setting yourselves up for future surgeries, right? So depending on where your fibroid is, if it enters the cavity, if it's really large, if there's multiple fibroids, you might end up requiring a cesarean delivery. And so when I have those patients who are incidentally found to have fibroids, whether it's through the fertility workup or they had symptoms, and so we looked for the fibroids and diagnosed it. When we're trying to decide, okay, should these be removed prior to trying to conceive or not, it is that balance of, okay, these fibroids based on size location might not impact your ability to conceive, but here are possible pregnancy complications that we'd be aware of, or these fibroids will impact your ability to conceive potentially, but you now have to have a C-section for all your future deliveries. And I definitely have had patients in that crosshairs of being like, wait, I was hoping for a vaginal delivery. Now you're saying I have to have a C-section for all my deliveries, which we also know have its own kind of possible surgical complication risk. How do you counsel patients in that really nuanced gray area?
Yes, that's such a good question and a conversation I have very often with my patients who come to me. So I think for many patients, they actually have been trying for a while and they didn't know they had fibroids
Hmm.
until it was found incidentally during their workup.
Hmm.
Um, and so a lot of my patients are also undergoing IVF. And so for them, they want to do all of the things possible to set themselves up for success because they've spent a lot of time and a lot of money getting here. And so for those patients, I think it's a little bit more easy to say, okay, if this is impacting my lining, if this is pushing against my lining, I just don't want to take a chance. And they want to proceed and just do the surgery. Now, it's as you said, now once you commit to that kind of surgery, then yes, you have to have a C-section. If you want to have another baby, you're always committed to a C-section at that point.
Hmm.
If we proceed with a robotic myomectomy, and I think a lot of patients at that point they're kind of resigned to the fact that that's fine if as long as they can get pregnant. They're not so much worried. I feel like about the C-section.
Yeah.
As what is right in front of them,
Yeah.
which is if is they haven't even gotten pregnant yet.
Hmm.
But yes, there's a lot of counseling to be done, risk of uterine rupture,
Yeah.
all of these things that we talk about. We remind them once they do get pregnant and they go to an obstetrician. I write that in my operative report.
Yeah.
I really make
I
sure
love
that,
getting your operative reports. You're so clear.
yes, they really, so that, people don't forget what I said or that, that they're following those guidelines. But yes, for many, it's difficult. I have some patients who say, you know what, let me just try. Let me just try
Mhm.
and get pregnant and let's see if it works out. Great. Like I was able to do it without, any of these interventions. And we know
Mhm.
it's possible, right? We
Mhm.
see patients all the time who got pregnant, never knew
Mhm.
they had fibroids.
Yeah.
They're already 20 weeks pregnant. And now on their scan, we're like, oh, did you know you had 4 fibroids? They had
Yeah.
no idea. And a lot of them go on to have vaginal deliveries.
Mhm.
And for some patients, they're okay just trying once or twice and then seeing what happens. So I think it really comes down to everyone's personality,
Yeah.
how much chance they want to take, how much they want to control, should do all of the things before. So it's really fascinating exploring this with different patients and their risk of their tolerance to risk as well,
Yeah.
right? So I think that's what it really comes down to, and that's what I counsel them about.
Yeah. You're practicing the finest art of medicine, which is the art of individualized care. And so much of
Yes.
those conversations I have with patients is it depends on your level of risk aversion, right? You could counsel 2 different patients with the same but you're just like me, we have the same kind of spiel that we give because we talk about the same things again and again that is evidence-based and empowering, but one patient will hear that and it will internalize in one way for them such that they would opt out of surgery. Another patient will hear that and say, "Nope, I wanna do everything I can to
Yes.
conceive." And you're right that by the time you see a lot of your patients, they've been undergoing a fertility journey, and they're probably at that point where they're feeling more ready than most to have surgery. What about for the patient who might be listening to this episode right now who doesn't necessarily know that they might have fertility issues? What are some kind of more obvious red flags or warnings for a woman who's maybe, again, not necessarily trying yet, but they might have symptoms that might be indicative of fibroids? What are those kind of common symptoms that they should be aware of?
Yes, so definitely the most common symptom is heavy bleeding. So many women with fibroids have always had heavy bleeding or throughout as much as they can remember in their 20s and 30s. But if you're bleeding over a pad or a tampon an hour, that is definitely considered too heavy. So you should seek care. But bleeding, pelvic pain or pressure, some people will say, I just feel like I'm having to pee all the time. I just feel some pressure. Others, painful sex is another big one, pelvic cramping. And then some people will literally can feel something moving as they turn like in bed from side to side. So those are some of the things to just watch out for. But I would say bleeding is probably the number one, heavy bleeding.
Yeah, yeah. Um, and you are out there as a fiber doc, and I know that you're out there trying to be a myth buster, which is so helpful. What do you think are one of the biggest myths on the internet about fibroids and fertility that you wish you can wipe out in one statement?
Drinking different tea blends are not going to shrink your fibroids.
I wish. I wish. Yeah, that's a good one. That's a good one.
Yeah. I think, we're in this area, this kind of era in medicine, in life, in just a social culture where there's a lot thrown at us. And I think many women with fibroids start to go down that algorithm, right, on Instagram or TikTok or Facebook about fibroids. And then suddenly you see all these ads for these teas and pills. And there are a lot of patients who've spent a lot of money doing these different things under the hope that they're going to be cured. And honestly, they've also wasted a lot of time, right?
Yeah.
Like, because
Yeah.
especially when it comes to people who are trying to get pregnant, time is of the essence and they're probably already starting late. And so it actually makes me really angry when I see those kinds of
Yeah.
myths out there that, if it was that easy, hey, we wouldn't be having 80% of patients, women with diagnosed with fibroids, right? Like
Exactly.
there's no easy answer. So I think that's like the biggest myth that there's these teas that are out
Yeah.
there.
Okay. No to the T's. Noted.
Yes. No.
And I think similar to you practicing the barrier, we have such a special patient population, a diverse patient population, a well-educated patient population. And I do respect there is a holistic approach to medicine. I'm gonna ask you about the kind of routine medication and surgical management of fibroids, but are there, besides the false teas, are there any, like, lifestyle modifications that people can make? I've heard things about, like, having a low inflammatory diet, reducing intake of alcohol, caffeine. Is there anything that you would say, like, don't won't make the fibroids go away, but can just be overall maybe helpful and not harmful?
Yes, absolutely. So reproductive health is health in general. So
Yeah.
I start to tell my patients about, eating well, focusing a little bit more on a plant-based diet. We know that
Mhm.
cruciferous vegetables help. So broccoli, cauliflower to either stabilize size of fibroids or reduce their size. This is one of the only pieces of like evidence that we have on that. So, exercising, getting good sleep, cutting alcohol, I have patients who tell me, like, yeah, once I started implementing those lifestyle decisions, like my pain actually like dramatically
Yeah.
decreased. I'm thinking of one patient right now who's actually was signed up for surgery or came to me for surgery, and then I talked to her about lifestyle, and then she actually was like, "Yeah, I don't think I need surgery right now." I'm like, "Fantastic!" Like, she was
Yeah.
able to actually change things around. So I really believe strongly in that, and that's how I start every conversation, cutting down smoking, like, or stopping to smoke, like, all of those things that we think are essential for health, general health, are
Mhm.
so critical for reproductive health. So, yes,
Yeah.
that there are some studies that show vitamin D supplementation can help, And vitamin D, I think overall has been shown in multiple arenas of health to be helpful. So that's something. If people are going to take one vitamin, I suggest vitamin D. Um, and yeah, so those are some of the lifestyle interventions, and definitely good sleep, because sleep is where our body repairs itself, our immune
Mm-hmm.
system needs it, and so that all drives down inflammation.
Yeah. No, I love it. And when we think about the more traditional treatments of fibroids, again, knowing that most of this audience is probably non-medical, what is the medication-based treatments for fibroids versus the surgical treatments, and what are some of the new up-and-coming treatments that you're for fibroids that you're excited about or aware of kind of in the pipeline?
Yes. So there's so many medications we can use now, and it really depends on what the problem is. If the main problem is bleeding, something as simple as birth control pills can help. We have a couple of other classes of medications that can also decrease bleeding during your period to make it a little bit more manageable. They're not going to take away the fibroids, but they can at least tackle the bleeding, which is
Yeah.
again the number one problem. If you want the fibroids to shrink, there are some medications and injections that we use for that, either oral pills or injectables that can help shrink the fibroids. So there's that. For those who are undergoing IVF or fertility treatments, I would always suggest a myomectomy. So actually removing the fibroid completely
Mhm.
if it's in the cavity or close to the cavity. So that's one. And then we have some radio frequency procedures like the Acessa, Sonata, some of those that can help shrink the fibroid through some necrosis and same day surgery, and patients do well with that. I think one of the things I'm most excited about is that radio frequency ablation vaginally.
Yeah.
We don't have it at our hospital yet, but I am going to try it out.
Yeah.
I'm excited for that one. So because it can be done very minimally invasive and
Mhm.
yet shrink the fibroid enough that it doesn't impact the cavity anymore, which would be great for those who want to proceed with pregnancy.
Yeah, and yeah, my understanding for with some of these newer radio frequency ablation options is what's the data around conception then after?
Yeah.
Are there emerging data to say that getting pregnant after these procedures is still considered safe?
I think generally they are considered safe. There are more studies now that support that. I don't think we have FDA clearance for that indication just yet. There's also some thoughts about the vaginal approach being a little bit more safer than the abdominal approach.
Mhm.
But we do know that we've had a lot of patients get pregnant after those radiofrequency ablation procedures. So I think it's just important to counsel patients. Again, everything comes down to risk and benefit.
Yeah.
Some patients may not want that kind of a myomectomy that then commits them to a C-section. So they're going to try every other option first.
Yeah.
Yeah.
Yeah, I think that's fair. As a fibroid doc, what is your it sounds like you're really excited about this vaginal approach for radiofrequency ablation, but for what exists right now, for the tools that you have in your repertoire right now, what's your favorite approach to managing fibroids? What, like, gets you energized?
I love doing a robotic myomectomy. I think
Yeah,
that
I
is
figured.
absolutely my favorite procedure. I think it's technically fun and can be challenging depending on how many you have, where it is, but also it gives me an opportunity to look into someone's pelvis. And you know what? A lot of times I find other things that can
Yeah,
also be a problem with fertility,
yeah,
especially endometriosis.
yeah.
So, a lot of, there's about a 40% coexistence of fibroids and endometriosis. So, a lot of times I'll see endometriosis that I can also remove for the patient at the same time. So, I love that procedure.
Yeah, yeah. I figured that was gonna be one of your favorite procedures. That's the times when I see you in the ORs, usually when you have your robot cases scheduled. So I'd like to take a moment to tell you this is my passion project based on years of experience as an OBGYN doctor. I aim to empower moms and moms to be and those in the pregnancy and postpartum care space. If you appreciate what I do, please take a moment to like, subscribe, and share with your friends so we can reach more people like you. You can visit goldenhour.fm for more information, resources, and all other episodes. If you have any requests, suggestions, or questions for future episodes, please email me at hello@goldenhour.fm or leave us a comment at goldenhour.fm on Instagram. When you think about the patient who might be coming to see you for a second opinion, right? So she saw another OB/GYN provider who recommended that, yes, you need a myomectomy, but based on fibroid size, location, we recommend an abdominal myomectomy, so an open approach versus a minimally invasive approach, whether it's robotically assisted or straight stick laparoscopy. How do you counsel that patient? And again, for any patient who's listening who's like, okay, I know I have fibroids. What's the surgery option that's best for me? Who's a better candidate for an abdominal myomectomy versus a candidate for a robotic or minimally invasive myomectomy?
Yes, that's a great question. We try to do everything minimally invasive if possible, because we know that it leads to quicker recovery times, less blood loss, all of that. So for me, size is an important factor. Usually I'll even do up to 14 centimeters or so
Yeah,
robotically. It also depends on how many there are. Is it one fibroid versus other eight fibroids?
yeah.
And then are we planning on removing everything?
Hmm.
For a lot of patients, I'll say, hey, we don't need to remove all your eight fibroids. Like these are the two things, these are two ones that are really impacting your cavity, and these should definitely come out. But you don't need to remove this other 3 centimeter ones, 2 centimeter one. Versus some patients will say, no, if you're going to go in there, I want
Take them off.
every single one removed. And I had a patient with 30 fibroids, and she wanted all of them removed. I
Wow.
think 32 was the final number,
Yeah.
because she was like, I don't want them to grow. I don't want them to come back as much as possible. So that changes my approach. I'm not going to do that surgery robotically. So it also depends on the patient's body. Some
Hmm.
people have a long torso, so we have plenty of room to put in robotic instruments, even if there's a big uterus. Some people
Yeah.
have a very short torso, so we just don't have that much working space. So these are the things that I take into consideration, and I always examine the patient and I kind of see, okay, is this going to be feasible robotically? And most of the time, yes, we can do it robotically. And if I know that something may have to convert to open, I have a pretty good idea ahead of time. And I let the patient know, yeah, this is probably 50-50. We'll see. There's also considerations like time under anesthesia, right? Just
Hmm.
because it can be done, it doesn't mean it should be done robotically. We don't want to be under anesthesia for 8 hours. We want
Yeah.
to be expedient and also take that into consideration. So there's all of those factors are what I think about.
Yeah, no, so well said as always. And it goes back to, I think, a constant theme in our conversation, which is individualized care, looking at the patient, talking to the patient, understanding what their total their goals are, right? If someone wants all 30 plus fibroids out, it's a very different surgical approach than the patient who only wants the most impactful fibroids out. And so I love that. And I hope that patients listening are thinking about the questions they should ask their OBGYN when they think about the best surgery for them. What are those questions?
Yes.
If you were the patient, what do you think
Yes.
are kind of the most high yield top questions to ask to really make sure they're getting the care that they deserve?
Yes. So I think the first question is just getting a good explanation of what types of fibroids you have and where they are. How are they impacting you? Because you may have fibroids, but they may not be impacting you in any way and you don't really need them out, right? So
Mhm.
how are they impacting you, or how could they impact you, especially if you're somebody who's trying to get pregnant? I think that's the first one. Number two is, yes, if you were going to do surgery, what would be the best option and why? I think that's really important to understand. Is it because, of how your torso is? Is it because of the number you have? Is it, what exactly is it? And the third and probably most important thing is for people to know what their goals are before they
Mm,
see a
I like that.
surgeon or even get a second opinion. Because a lot of times I'll see patients and I'm like, okay, what's your plan? Like, are you planning on getting pregnant? And if you don't know the answer to that, that's going to be, it's going to change what we do entirely. Versus
Yeah,
if you're very decisive, actually, I'm not planning on getting pregnant. Well, then maybe a hysterectomy is on the table for you. Versus if you are planning on getting pregnant and using your uterus, that's not an option. So
yeah,
being a little bit more clear on what your goals are, I think that's really important prior to seeing somebody. And then when you see a surgeon, always ask like, hey, have you done these procedures a lot? Like how many have you done? Or, what's your level of comfort with these procedures? It's never a bad question to ask.
yeah, yeah.
Yeah.
No, so thoughtful. I love it. Okay, so now let's transition to a topic that the algorithm loves, but unfortunately does such a terrible job to explain, hormones, okay?
Yeah.
So you are a certified menopause practitioner. How do you approach hormonal therapy in a way that leaves your patients feeling empowered?
Yes. This is a big topic, and everyone, I think, at this point, we have a culture moment where
Yeah.
menopause is out there. getting the attention that it finally deserves. And I think a lot of patients are chalking up a lot of symptoms they have to hormones. So many are
Yeah.
coming in their 30s and 40s and they're like, could this be my hormones? Am I in perimenopause? And so the first thing I do is just really listen to them and see what their complaints are, what their problems are, and also take a good history because a lot of times these may have nothing to do with the hormones. They could have other medical conditions that are causing some of these symptoms. So really understanding all of that, I think,
Hmm.
is the majority of my visit. And then, I also talk to patients about there's nothing called balancing hormones, right?
Yeah.
There's no balance. Like for everyone, it's different, and everyone needs a different ratio of hormones to feel good. So then we may do some testing. We may, or if it's very clear cut that the patient needs hormones, we some hormone supplementation, we do that. And then it's like, well, okay, what hormones do we want? We have estrogen, progesterone, testosterone. Where do all these fit in? And have we tried some other medications depending on your age and menopausal status? Or is this really the best? So, yes, so it's a very multi pronged approach
Yeah.
that I take, and I don't really believe in like a huge battery of testing that then just tells you, yes, you must take hormones, or no, you don't need it. It's much more nuanced than that, and I think educating patients is really critical, and that's what I spend a lot of my time doing.
Yeah, no, it's so true. Perimenopause and menopause is having a moment, if you will, and well deserved, right? You and I both know as OBGYNs, it's been a long time that women unfortunately suffered in silence. But it also means there are many people who are taking advantage of the press and the wave of information, or wave of attention rather, and using that to disseminate misinformation. So that's why what you and I do one-on-one with patients in the clinic is just as important as this conversation here with hopefully a wider audience, because I think people are trying their best to break through the noise and find some truth, because they do want to feel better, they do want to understand their bodies better, but there's a lot of noise out there. What would you say besides, I think you brought up a phrase I hear a lot from my patients, which is like balance hormones, quote unquote, which, as you already alluded to, is not necessarily possible, or the right way to think about it. What's one piece of hormonal therapy related misinformation that you also hear out there a lot that you like to debunk? Just like the fibroid tea, what's the big one that's like your big menopausal therapy pet peeve?
I think my biggest one is the use of pellets.
Yeah.
Actually, yep.
Yeah.
I have a lot of patients even before they see me, they've done research on pellets. They think that's gonna be their magic, cure to everything. So that's probably my biggest pet peeve because not only is it not FDA approved, we don't have good data on it, and then I have
Mhm.
to kind of deconstruct that and then approach like, the right way of thinking about it. So
Yeah.
I would say that, and then probably the second one is patients thinking that a lot of what's going on with them is hormonally related, which
Mm.
maybe for some, but for others, it's not. Patients are, it's really fascinating. We live in the Bay Area with overall, as you said, educated, healthy patients, but the amount of high blood pressure that I diagnose in the office,
Yeah.
cholesterol, sleep apnea, all of those things can also make you feel pretty ill and not
Yeah.
feeling to your feeling your best. And so I also am doing a lot of primary care in my office because many patients don't have a primary care doctor. And I think it's so important to realize again, basic health is hormonal health. So if you don't have that, then
Mm.
of course, as you reach perimenopause and menopause, you're not going to feel well because some of your basic building blocks are not in place. So
Yeah.
that's like a big thing that I'm very passionate about educating everyone on.
Yeah, no, I love that. I mean, any good clinician is gonna look at a patient holistically. It's not just gonna be like, "Okay, you're here for some hormones, here you go." No, you're thinking about their lipid panel, because we know, risk of cardiovascular disease as it relates to hormonal therapy. You're thinking about other, very, very common perimenopausal, menopausal complaint is fatigue and lack of feeling like a good quality sleep. But oh,
Mhm.
maybe it's because you have sleep apnea, right? You have to think about all the multiple factors that can affect someone's overall health. You mentioned the three kind of main hormonal treatments that we offer patients: estrogen, progesterone, testosterone. So for the person listening right now who's not clinical like us, how do you think about those three medications, and what are they generally used for, and should a patient kind of approach trying to figure out if that's something they should consider?
Yes. So estrogen, I would say, is the secret sauce for a lot of what we feel during perimenopause and menopause. So if a patient comes in with the hot flashes and the sweats and mood changes and brain fog and all of those things, I think estrogen is the first thing that I think about that their ovaries are sort of petering out on. So we definitely consider estrogen for those patients. Now, if you have a uterus, I think many patients don't think about it this way, but the real reason for giving progesterone is to protect your uterine lining
Hmm.
if you do have a uterus. So if anytime we give estrogen, it has to be balanced with progesterone. So those two often just go together and come in many different forms: pills, gels, sprays, patches, rings. And then when we think about testosterone, currently we're really using that for postmenopausal women who have low libido. So this is not really for muscle building, it's
Yeah.
not for things like that, but it's really for low libido. And then as a side effect, some patients will say, "Oh yeah, like my mood was also a little bit better," because we know at premenopausally we have a lot of testosterone. And so that's sort of where that fits in.
Yeah, no, really helpful to break it down, and in that, I think you explained the nuance where, there's so many ways that our body changes through perimenopause and menopause, physically, emotionally, mentally, all of the above. And sometimes patients will equate, yeah, estrogen is definitely the secret sauce, but sometimes patients will equate the hormonal medications to other potential benefits that haven't been founded, right? So I have patients who will come in asking about testosterone because of, muscle wasting or
Mhm.
loss of muscle mass, and have to really kind of carefully explain, like, no, this is primarily for libido. It's it's not meant to, or I can't promise you that's gonna help with your muscle integrity, and I think that's so much of our job is educating. It's not an empowering. It's not about, making shaming anyone for not understanding, because of course they're getting their information the best way they can, but making sure that patients are making a well-informed decision about what medications are options for them and the risk of the medications, and ensuring that those benefits far outweigh those risks.
Yes, and the other thing that I, also screened for earlier on is osteoporosis.
Mm,
So even though the official recommendation is 65, I do check, right around perimenopause, and many patients will already have osteopenia. So even if they feel well otherwise, estrogen has been shown to help with bone mass and preventing onset of osteoporosis who in patients who may have otherwise gotten it earlier. So that's another kind of thing that patients may not feel, but something that is important to look at.
yeah, yeah. No, I agree. I think that hormonal therapy has so many known benefits and also unknowns. I think something that you alluded to at the beginning of our conversation is that women's health research is lacking. We're getting there, but between fibroids and endometriosis, let alone, perimenopause and menopause, we only know what we know. And I think that there are emerging evidence about different ways that estrogen can affect multiple body systems, and therefore how hormonal therapy can help. But we don't have those studies fleshed out quite yet.
Mhm.
What are some emerging pieces of evidence or studies that you're aware of that make you feel hopeful about the advancements of women's health, or and our ability to care for our patients even better?
I mean, I think just debunking a lot of the WHI
Yeah.
studies claims in the beginning has been a huge, change and improvement in the right direction. I think the recent removal of the black box warning on vaginal estrogen has been great because we know how much vaginal estrogen helps as well. So I think these are the right trends. And
Mhm.
then really educating the doctors.
Yeah.
This is something that, I don't know about you, but we didn't really learn a lot in residency about
Yeah.
menopause and how to prescribe hormone therapy. It's just sort of like we saw some attendings do it in outpatient clinic and that was it. Like, there was no
Yeah.
systematic education about it. So just an emphasis on more people investing time in learning so we can provide this care to our patients. So that's really, I think, empowering and moving in the right direction.
Mm.
And as far as research, I think I would love to see more research on testosterone, even in younger women, like in
Yeah.
perimenopause, and for other reasons, including mood.
Yeah.
So I would love to see that, I think, as a next step.
Yeah, I love that. No, and you're right. I still remember, in my training, I think the attendings I had were excellent and brilliant people, but I think they were still very much affected by the WHI study. So the counseling I received back then was, limit hormonal therapy use, it should only be used for a max of 10 years and it only should be used up to the age of 60. And so I really walked away from residency, honestly, kind of being scared of hormonal therapy, being like, okay, and I trained at UCSF. I trained in the Bay Area, again, by brilliant people. And in that time, yeah, the WHI study has definitely been debunked in a really important way. And I agree that it's up to us providers to educate ourselves and re-educate ourselves, because even for my newer colleagues who are joining our group who didn't necessarily get the same teaching as me, they're not necessarily as fearful as hormonal therapy. They don't know it yet either, right? That most of training for as an OBGYN is about surgery and acute inpatient hospitalization and things that require, a lot of skills. But the art of medicine, the nuance about patient care, you don't really gain that skill set, I don't think, until you're practicing. But I think there should be more and more emphasis as newer colleagues are leaving training to say, hey, get that medicine certification out of the way, right? Come in with that extra level of knowledge that we, to no fault of any training program, it's hard to get that in training.
Right, right. Yes. And it's encouraging to see more people doing that training and more people practicing evidence-based medicine, going to the conferences, the menopause meeting, the Issue-ish conference, and really empowering themselves to do it. And of course, there's the time factor, right? There's also
Mhm.
that in medicine where our appointments are, rather short in a lot of practices, and that doesn't lend itself to the best, like, long conversation on hormones. And this is where I think social media is so great if it's coming from these physicians, because we can
Yeah.
put out really educate patients on a larger basis there too.
Yeah, yeah. No, I think you and I are both using our voice for good, and
Yes.
I'm grateful for that. Thinking about these patients that we get to see every day, one on one, and I'm biased. I think you and I give our patients the best, most honest and dignified care that we can. What's one thing that you would wish that you can tell every woman in order to advocate for themselves when they're in an exam room, right? They're not sitting across from you and I, and they might need to take up more space in the room and make sure they walk away from that consultation feeling heard and with a plan that really supports them. What's one wish that you'd have for our patients?
Yeah, I would say just ask questions.
Mm,
Sometimes I think doctors assume that our patients know some of the basic information, and I've been surprised at times that
yeah,
they don't. I still have patients asking me all the time, like, "What is this PAP testing for again?" We're all
yeah,
told we need a PAP, we get a PAP, but, like, well, what is it actually?
yeah,
And is it for ovarian cancer? Is it for uterine cancer? No, it's for cervical cancer. So something that we just take for granted, right? So if you have questions, ask them. And then, now it's amazing with things like ChatGPT and Cloud and all of those forums. Patients are a lot more educated as well before they come in,
yeah,
so that's a little bit, it's good because they already come in with a certain, frame of reference. But if you still have questions, I would just say ask. And if you feel like it's super rushed, and make 2 or 3 appointments next. Like, I mean,
yeah.
I hate to say that, but, like, that's just how you have to get into the healthcare system sometimes,
Mhm.
because we want to give all our information that we have, but it's very hard to do in a shorter appointment time, right? And we can't cover multiple topics. So I always sometimes tell patients, make multiple appointments, like several in a row, so that you are still getting all your questions answered. And then make appointments with doctors who you think are going to be experts in the field that you, or the topic that you want. Not all doctors are equal. We all have a amazing breadth of knowledge, but some of us are more, some of our excellent obstetricians, some are excellent surgeons, and we all have different, like, niches within our own specialty. So do the research beforehand, I would even say, to make sure that you're getting the biggest bang for your buck when you are making that appointment.
Yeah, no, I love that. And you're right, those appointments can feel so rushed and it's not the desire of the clinician, it's the way that unfortunately the healthcare system works. And so I always encourage my patients if I'm seeing them and they have a laundry list of things they want to go through. I'm like, all these are important and they all deserve time. And so we're going to need probably subsequent appointments so that we don't kind of hurry what is so important to you and therefore important to me. And there's ways to work the system. And I think that that's such beautiful advice. Okay, so we're wrapping up, which is sad because this is such a fun conversation. But I always like to end on questions like this because it really helps not only me, but the audience see the person, the clinician that you are. What is one belief in women's health that you hope will be completely different 10 years from now? Take your time.
That I would say that what we are experiencing is true.
Mm,
I just had a patient today who had, she's had multiple kids, kind of a strong woman,
yeah.
high pain threshold, and she was like, I'm just having this pain. It's weird. I don't know what it is. So we're doing all this workup and everything is coming back negative, negative, negative. And so we had an appointment today and she's like, oh my gosh, everything's negative. Is it all in my head? Like, I don't understand, but I swear
Yeah.
I'm having so much pain. And I was like, no, it's not all in your head. Like, you are having pain. All of the things that we've done are negative, but that means we have more work to do and we have to figure out
I love
what
that.
is causing it. So here, let's try this. Like, let's reach back out in 2 months. And so I think a lot of women um, think, what I'm feeling, what I'm going through must either not be true, it must be in my head, because, unfortunately, sometimes we've been told that. And
Mm-hmm.
sometimes just the subconscious messaging that we get is that, what, it's not that important, or get
Mm-hmm.
over it, right? And so I think that I wish that would change, and that really goes across so many areas in medicine, not just in the doctor's office, but when you go to the emergency room.
Yeah.
Yes, what I'm feeling is legit. What I'm feeling is real. I'm not a drug seeker, right? So
Yeah.
it spans across so much of what we do. And I think I that would be my hope, that in the next decade that we are more skilled, and to pick those things up, that we have more compassion to tell patients that, hey, I'm sorry you're going through this. We haven't figured it out yet, but let's keep
Exactly.
going.
Exactly.
Yeah.
You gave me chills there. And as I heard your anecdote, thanks for sharing. I see the faces of multiple patients who've had similar experiences, or the frustration when I tell patients like, hey, everything is normal, quote unquote, negative, but it doesn't invalidate what you're feeling. We just haven't, yeah, as you said, we just haven't found it yet. And yeah, I have to believe in the field that we joined, right? That I think most of us who go into medicine, it's because we're eternal optimists and we're idealists, and we do believe in change, we do believe in healing, and I have to believe that our field will get there.
Yes.
Cheruba, thank you. This is like the perfect
Yes.
note to end on. We're ending on in a space of hopefulness, a space of determination. I think this conversation reminds me of how important it is to treat the person in front of them, how important it is to create space and listen to the women that we have the honor of caring for. So thank you for sharing your expertise, your passion, your skills as the hashtag fibroid doc. Anything else you want to share with us before we close up?
No, I mean, this has been just such a pleasure. I've watched you grow, and
Oh,
I've just seen, so glad that we're colleagues, working at the same hospital. And yes, thank you so much for having me. And if anyone out there wants to see the fibroid doc, my practice is in Lafayette, and you can find me online across all social media channels as the fibroid doc. Thank you.
it's a perfect title for you. You wear it so well. Oh, thank you again, Shruba,
Thank
and
you.
enjoy the rest of your day.
All right. Thank you. Bye.
Bye. Thank you very much for listening to The Golden Hour, the podcast community where moms and moms to be can hear stories from other mothers and learn from top experts in pregnancy and postpartum care. If you enjoyed this episode, please take a moment to like, subscribe, and share with your friends so we can reach more people like you. You can visit goldenhour.fm for more information, resources, and all other episodes. If you have any requests, questions, or suggestions for future episodes, please email me at hello@goldenhour.fm or leave us a comment at goldenhour.fm on Instagram. Looking forward to seeing you in the next episode. Until then, stay golden.